Assalamu alaikum ji. So the topic I've been given to talk today is the management of dislodged devices via stents, balloons, and catheters. It's a huge topic, so I'll try to cover as much as I can in the next 10 minutes. Major complications of percutaneous coronary intervention are rare but can be catastrophic if not successfully managed. Operators should therefore be prepared for complications, especially if they intend to perform complex and high risk procedures. Dislodged and entrapped equipment is a rare but particularly challenging complication that can be encountered during PCI. Given the variety of equipment that may be retained in the coronary artery and the multitude of mechanisms by which it may be entrapped, there is no straightforward techniques that can be applied to all the devices. So I'll be going over a few flow sheets and discussing various methods that can be encountered and applied to get out of this situation. So stent loss is one of the main things that can happen. Coronary stent loss and embolization, although now very infrequent, has not been eliminated entirely. The most frequently lost device is a stent, slipping of the delivery balloon in the coronary circulation. Dislodgement of a stent may result in systemic embolization and cause cerebrovascular events, whereas if it goes into the coronary, it's definitely associated with an increased risk of thrombosis and myocardial infarction. So management, knowing the management and knowledge of this complication could avoid a bailout cardiac surgery and serious complications such as stroke and a myocardial infarction. Stent loss and embolization, although infrequent since factory crimping was introduced, has not been eliminated entirely. Retrieval techniques are technically challenging and evidence for their success is limited to case reports. The key principle is to bring the foreign body down into the iliac artery where it can be removed rather safely. The position of the guide wire will be crucial in the choice of the technique. Indeed, some techniques are not possible in the case if the guide wire is lost. So taking great care to keep the wire position inside the stent may be paramount in this situation. For stent loss within the coronary circulation, the key principle would be successful retrieval to keep the guide wire in position secure at all the time. So the four main scenarios that can be encountered with the stent loss are that there's a partial stent loss in the coronary artery, there's a total stent loss but the wire is intact, the stent is lost along with the guide wire, and the stent loss is in the aorta or a peripheral circulation. So I'll be going over each of them one by one. So in a partial stent loss, dislodgement can occur if it's being stripped off the balloon while crossing a tight lesion. It can get partially stuck within the lesion and become separated from the balloon while it is being withdrawn. And when withdrawing a deformed stent, a stent tine may catch onto the guide tip, having been partially stripped off the balloon. So if that happens, what we can do is that there are certain techniques that can be done. The simplest is to inflate a stent balloon at a very low pressure, 3-4 atmospheres, so that it sort of catches on to the stent but doesn't really oppose it to the wall and brings it back. Another method would be to pass a deflated balloon across the stent and then inflate it at a low pressure and sort of pull it back like an anchor. If all that fails, retrieval techniques other can be employed which are also applicable to the complete stent loss. So I'll discuss them in the next slide. This is a small video which is showing the first technique, so that we take a balloon, put it inside the undeflated stent, inflate it just to about 3 atmospheres so that it just sort of catches on to the stent, and then pull it back into the catheter. So this is the first technique. The second is that we take the undeflated balloon across the stent and then inflate it and then pull the balloon, and that sort of brings the stents back with it into the catheter. In case there's a total stent loss, again we'll try to do the same thing, try to pass a small balloon to recross the stent, inflate it at around 3-4 atmospheres and sort of bring it just like I showed you in the first video. In case that fails and the vessel size is acceptable to inflate that stent at that point. So we're talking about a stent that's lost and we can't get it back through any simple technique. So the sort of manageable situation is to inflate it at that position if the vessel size is acceptable, and we won't expect any ISR or any stent thrombosis in that case. In case there's a mismatch, what we can do is, if it's in the proximal segment of the vessel, we can try to snare it back. I'll be showing a video for my younger colleagues as well. And if it's in the distal segment, then a multi-wire technique can be used to bring it back. So this is a video showing the snare technique, in which a snare, loop snare, this is a video showing, in which we sort of, if the vessel, if the stent is placed a bit proximally, we can sort of use this loop snare or any other snare to catch on to it and then bring it back into the catheter. And this is a video showing in which multiple wires are basically passed, and then they are entwined on each other, so they sort of grip onto the stent. And once we've given it multiple rolls and we see that the stent is captured by these wires, then we can sort of start to pull on these wires and they bring the stent back into the catheter with the wire. So in the first technique, if this vessel size is acceptable, you can inflate it over there. In case there's a mismatch, another thing we can do is that if the stent is placed proximally and it was intended for a distal part, what we can do is that we can inflate a balloon before the stent, proximal to the stent at a lower atmosphere, and sort of push it with the balloon to a distal segment where it was actually intended to go, and then pass a balloon through it and inflate it over there. In case there's a total stent loss and a guide wire loss, and we are not able to pass a wire back through the stent, then the only thing is to use a snare and try to retrieve the stent. And if that fails as well and we're not able to catch on to the stent, for example, it's very much opposed to the wall, then the next thing to do is the best option available is to crush the stent. Take another stent at the place where we can steal the stent and inflate it at a higher pressure and crush the stent with the wall. Obviously, this will raise the possibility of thrombosis, but this is the best situation that we can get out of at this time. So this is just a diagram of all the snares that and all the tools we have available. The first is a loop snare, second is the end snare, and the third is the basket, fourth is the biliary stone forceps, fifth is biopsy forceps, and sixth is the fragment retriever. This is just a diagram of all the forceps that we can use. In case there's a stent loss in the aorta or the peripheral arteries, first thing that we can do is, if we can see the stent and it has gone onto the cerebral and carotid arteries, the best is to contact a neuroradiologist. If it's above the common femoral artery, we should use a snare to bring it down to the iliac artery or the femoral artery, and then try to retrieve it through forceps or any other methods. If it's below the common femoral artery, some studies have shown that using a conservative management is suitable. So that's all for the stents. In case for the guide wire dislodgement, I have very less time available, so I'm just going to rush through it. There are three sort of scenarios. One is if the part of the jailed wire is behind the stent struts. So the best is to use the snare, and in this case we're going to use the end snare to catch the wire, or using a multi-wire technique may be applied as well. Obviously, if that fails, surgery is always going to be a backup option in all these complications. So this is the enfold snare, trifold end snare. In case part of the jailed wire is behind the stent struts and confined to the coronary artery, and if we can identify the fractured side of the wire, we can use a micro snare or a multi-wire technique to get it. If that fails, then another thing that we can do is we can inflate another stent where the loose portion of the wire is visualized and pose it to the wall by using another stent. Surgery is always going to be a backup option with us. If the guide wire is lost and it's free in the free intracoronary fragment in the coronary, we can use the snare to get it. Wire aspiration using the thrombectomy device can be done. It can be fixed with an additional stent, or it can be tracked with an extension guide catheter. Multi-wire will also be another option available to us. In case of, that's also the wires. In case of the balloon fracture, if the shaft of the balloon fractures and it's in the guiding catheter, the best thing we can do is to use an NC balloon and inflate it in the catheter and sort of pull the entire apparatus together, and that will pull the guiding catheter and the balloon with it as well. If the balloon shaft is it's outside the catheter, then the same options are available to us. We can use a snare first of all to get it, and if that fails, then obviously surgery is going to be our main go-to option. Similarly, as the balloon catheter, the rotabar shaft disconnection is going to be the same if it's in the catheter guiding catheter, we can use a balloon trapping technique, and if not, then snare and surgery are going to be the options. PCI is a common invasive procedure with a relatively low complication rate now. However, when complications do occur, operators may be unprepared to manage them. So having a definite backup plan helps you and makes you more confident to tackle and take on more challenging cases. Thank you.
Thank you, Dr. Noor Dastagir. Dislodged devices and how to manage this he presented very well. So I will take 2-3 questions. After that, we'll take a final comments from the panelists. So any question?